The endocytoscopy system uses ultra-high magnification endoscopy to visualize living gastrointestinal cells with vital staining and enables real-time endoscopic assessment of histology, endoscopic optical biopsy. The use of ultra-high magnification with endocytoscopy makes it possible to differentiate between cancerous tissue and non-cancerous tissue, and has been applied to the pharynx, esophagus, duodenum, and colon. However, vital staining is generally poor in the stomach because of gastric secretions and inflammatory products, making endocytoscopic observation more difficult than elsewhere in the gastrointestinal tract, which is lined with squamous and columnar mucosa mainly composed of absorptive cells. Therefore, studies on endocytoscopic observation of gastric cancer have been very limited. Using double staining with crystal violet and methylene blue, with repeated and careful water rinsing and dye applications, the authors recently performed a feasibility study of endocytoscopic diagnosis for early gastric cancer. Of 82 lesions, including 23 early gastric cancers, 88% of all the lesions and 91% of gastric cancers were accessible by endocytoscopy. Lesions covered with dense mucus, such as hyperplastic polyps, were not well assessed with endocytoscopy because of insufficient vital staining. High-grade endocytoscopic atypia was observed in 86% of accessible gastric cancers, but not in any of the gastric adenomas or non-neoplastic lesions. Based on this criterion, the sensitivity and specificity of gastric cancer diagnosis by endocytoscopy were 86% and 100%. Respectively. However, this pilot study involved only one expert endoscopist who made endocytoscopic diagnosis with a carryover effect derived from the preceding white light endoscopy or narrowband imaging (NBI). This study therefore sought to evaluate whether the defined criterion of endocytoscopic atypia could provide sufficient diagnostic accuracy and concordance amongst endoscopists with different levels of expertise when bias due to a preceding endoscopic diagnosis was avoided. Kaise et al. Therefore sought to verify whether endocytoscopic atypia can provide satisfactory levels of diagnostic accuracy and concordance amongst trainee and expert endoscopists. Method. A total of 100 lesions evaluated by endocytoscopy and histopathology were enrolled to create an endocytoscopic image catalog. 44 early cancers, 10 low-grade adenomas, 46 non-neoplastic lesions. 4 endoscopists, 2 trainees and 2 experts, independently reviewed the catalog images and evaluated each of them for the presence or absence of endocytoscopic atypia. Results. High-grade endocytoscopic atypia was observed in 78%, 18%, and 4% of cancers, adenomas, and neo-nonplastic lesions respectively. The sensitivity, specificity, accuracy, and positive and negative predictive values for cancer diagnosis by endocytoscopy were 78.4%, 93.3%, 87.3%, 85.4%, and 87.3% respectively. The concordance rate for the results of high-grade endocytoscopic atypia was good among the 4 endoscopists, K-value 0.682. No significant difference in diagnostic accuracy or concordance was observed between trainee and expert endoscopists. Conclusion. Using the defined high-grade atypia as a diagnostic criterion of cancer, endocytoscopy provided a satisfactory level of accuracy and concordance for the diagnosis of early gastric cancer, regardless of endoscopic expertise.